use the opportunity to ask questions to leading specialists in their spheres. So, Anssi, the floor is yours, please.
Okay, dobré utro.
Good morning.
Anton, for the introduction. Thanks for the organizers for inviting me over. I'm very pleased to be here and try to spread the word about how to use epidemiological approaches in medical research. And this first talk that I will give is just an introduction, give some basics, some background for the next 3 days, and mainly hint at the topics that will be covered in detail subsequently. So basically, here I'm talking mainly about clinical epidemiology and evidence-based medicine. So I think traditionally the teaching at medical school is based on things like this. So there were discussions at the rounds and maybe some diagnostic examinations, and then talking about the basic sciences, pathological mechanisms and so forth, and then everybody's supposed to gather about how to deal with the patients, even if the relationship between the textbooks and the clinical reasoning is sometimes a bit unclear for the medical novice. And I think, and it was actually this what brought me into epidemiology when I was halfway through medical school and trying to grasp about how am I ever supposed to deduce the diagnosis from a long list of symptoms and findings that seem to go on forever, and asking about medical teachers about the logic of it. They say, well, with experience you will develop a clinical eye that will tell you what is the correct diagnosis, and I found this very unsatisfying. So at that stage, I happened to read a book called Rational Diagnosis and Treatment by a Danish gastroenterologist called Henrik Wolf, and he wrote about the epidemiological approaches to clinical reasoning based on probabilities. And that was the first thing that didn't really make sense to me and guide me about how to make diagnosis. And I think so, therefore, the revelation for me to find out that, okay, even if at the bedside we are mainly interested in the clinical details, what are the findings in examination, what kind of symptoms does the patient have, then that is, of course, very important in decision making. Equally important when we have a patient encounter is that really there are two sides to it, to incorporate the patient's expectations and understanding and values and preferences. So it should be an interaction in proceeding about the decision making. But of course, a physician is not really alone with the patient, but in reality we are always working within a healthcare system, within an organization that sets limits to what we can do and guides in the decisions. So it's not, so there are always some limitations to the degrees of freedom, what we can do, what is possible. But what I'm going to talk about today, and this whole workshop is about, is what is common for all healthcare systems, I believe, which is the scientific knowledge that should be there. So that if a patient or a young physician starts asking, why are we doing this, then I think in the end we should always come to the scientific results, which should be the solid basis for clinical decision making at all stages. And this is, I think, where evidence-based medicine starts, emphasizing that we need to have valid, proper scientific research to justify all of the decisions that we are making with the patients. And that, of course, the basic idea that we should use scientific methods in medicine is not novel. It's been there for at least 200 years. What is new in evidence-based medicine is that it requests direct evidence, that is evidence based on patients, not only cells or biology or physiology, but really observations on real patients, studies on clinically relevant endpoints, such as cure of the patients, improvement in patient status, well-being, welfare, perceived health, quality of life, and so forth, either cure or palliation of symptoms. So what evidence-based medicine requires us is to produce knowledge that is really based on real patients and those treatment outcomes that we are seeking in therapy. So this is the first topic that is brought forward by evidence-based medicine. The second one is the importance of randomized trials and the highest level of quality that can be reached in medical research is through randomized trials. They are the most reliable means of producing medical knowledge. And the third leg to stand on for evidence-based medicine is that besides having those randomized trials is pooling them, creating synthesis of all of the medical evidence that there is through systematic reviews. So that we should not be only looking at what is the most recent trial, but really compiling all of the evidence that there is on a research question. And that's where clinical collaboration, for instance, started. In reality, the amount of medical research is truly staggering. There have been estimates that there are more than 1 million medical articles published annually, which means that there are more than 2,000 new entries to the Medline each day. So it's really impossible for anybody to follow all of that progress. So even if you would be highly interested and if you would have hours per day to follow the literature, it cannot read everything. You cannot really assess everything. So therefore, we need to have this kind of synthesis, sort of filters as to evaluate what is the current status of knowledge, what is the current understanding of a given question. And the hierarchy of evidence was suggested maybe more than 20 years ago with the idea that these kinds of one of the slogans for evidence-based medicine is ask for evidence, not for eminence, meaning that however authority figure would be saying at the grand route, the professor of this department, that okay, this is how we should treat the patients. That is not sufficient, but we should really look at the evidence. So opinion, experience, and preclinical studies are the least important form of evidence for medicine. Then case reports and case series, they are based on real patients. They are quantifiable, they are empirical, they are more objective. Then non-randomized comparative studies, cohort studies typically, and then of individual studies, the randomized trial is labeled as the most valuable, the most reliable. But then on top of the pyramid, there are systematic reviews with meta-analyses of several randomized trials. However, it's become very clear that it depends, of course, how strong evidence is needed, also about the size of the treatment effect. So basically, for small to moderate treatment effects, we really do need randomized trials. We do need meta-analyses of randomized trials. For treatments that have large effects, number needed to treat around 10, so 1 patient out of 10 benefiting, avoiding death from the disease, for instance, then it's probably not necessary to conduct tedious, long-lasting, expensive randomized trials if the effect is really apparent. And if there is a almost invariably lethal disease that can be cured, a number needed to treat being low, let's say below 5, then it probably would be absurd to require randomized trials. So that in that case, when we have incurable disease and an effective treatment emerging, then it'd probably be unethical to do randomized trials. There was a nice piece in a Christmas issue of BMJ, for instance, writing about the effectiveness of parachutes in aviation accidents and saying that, there's never been any randomized trial, and we would ask any evidence-based medicine advocate to join a randomized trial of parachutes and be randomized either to receive a parachute or not, to figure out whether it's useful. So just a joke, of course, but really showing that there are some cases where we don't need randomized trials. In most cases we do, because it is very uncommon that there would be such a novel, groundbreaking therapy. Now would be such a dramatic effect. And just to show something about the importance of randomized trials. This is a rather old meta-analysis of beta blockers after myocardial infarction, used for secondary prevention of death from any cause. And this panel shows the randomized trials. So there are many, and they are very small, especially the early ones. So each line represents one trial. There's a confidence bound, and well, you cannot really see the point estimate there in the small ones, but in the large ones. So the larger trials have the larger dot or square indicating, and of course, more narrow confidence bound. But these are the results of the single randomized trials, and not everyone is showing an effect. Some are even suggesting there might be adverse effect, increased mortality. This is this solid line represents 1, meaning no effect. Anything on this side is above 1, favoring control or suggesting adverse effect of treatment, and then towards this side, these are smaller risks, that is therapeutic advantages of the treatment. And in the end, there is the pooled estimate, which is about 0.8, suggesting a 20% relative risk reduction, or odds ratio to be precise, by treatment. But the lesson is that, okay, we have a large number of trials, and none of them probably is sufficient alone. But here is cumulative odds ratio. So the evidence is always pooled, so that all of the previous trials are combined, and this shows nicely, so that when you pool the trials already at this stage, there is quite a bit of evidence combining those first 6 or 7 trials, and after that the estimate doesn't really change that much, and even the confidence intervals are already narrow by, let's say, 1982. So by pooling all of these small trials, you can really get a much more accurate, much more precise understanding about the effect. And that's why we need to really compile all of the studies, which alone might not be informative enough. Okay, so I believe that evidence-based medicine provides an opportunity to be more comprehensive, more systematic, more effective, and more critical, both towards our own work and towards the research that's being conducted. And it does also set certain requirements for us. So medical doctors should keep up to date with the medical research, because if you really are going to follow the current medical knowledge, then you have to know what it is. So read the literature, follow guidelines and systematic reviews, because they are good means of obtaining a broader understanding compared with reading each and every single trial. And also for the latest evidence, if you just read something that's not been included in any systematic review yet, it is important to develop and maintain critical evaluation skills, scientific reading skills, I would say. Understand how reliable, how valid are the results of a given randomized trial or other kind of evidence. But equally importantly, it also requires the researchers to focus on questions that are really clinically important and not only of academic interest, and study them using such approaches that we are able to obtain better understanding of the questions. And the typical questions that would be there to be addressed, for instance, how accurate are our diagnostic tools? I think diagnostic research is a sadly ignored area of research in medicine. How precisely can we predict prognosis? This is something that we would need for making treatment decisions. How effective are our treatments? That is the mainstay of evidence-based medicine. This is where most focus is. But also during the next days there will be also a screening conference here. So one of the questions is, how can we best screen for cancer and other diseases? How can we make the most of available screening tests, and which ones should we prioritize, who should be targeted, and so forth. And also for public health person, how effective are our prevention strategies? So it is, I think, equally important as treatment questions, and probably when focusing more and more on cost effectiveness of medicine, there's probably something where we could gain quite a lot more. Clinical epidemiology is just one way of tackling these questions. Basically, it is a study of occurrence of disease outcomes, including also those factors that affect the disease outcomes. They could be treatments, they could be delivery of healthcare, organization of healthcare, any other approaches that there are to affect the disease outcomes. Looking at other prognostic factors, for instance, patient characteristics. And what it means is basically is study of probability of outcomes in groups of patients. Meaning that we need to collect large materials, we need to make systematic observations, we need to think in stochastic terms, try to collect events and express them as probabilities and then risks. So this is basically the approach that we use in epidemiology, and there was also a famous 19th century French physician, Pierre Louis, who already said that without the aid of statistics, nothing like real medicine is possible. Just showing that, okay, we need to systematically record what are the outcomes of our own patients and study them. And an old definition of an epidemiologist is a physician who can count, just meaning that you need basic algebraic skills to be an epidemiologist. And basically, I wouldn't like to see an epidemiologist who cannot count, or a physician who cannot count, so meaning that basically all physicians should be epidemiologists. So you be able to apply some clinical algebra, so to speak. And yeah, the questions are typically formulated as what is the probability of a given disease if a patient has a specific finding in a clinical examination, for instance. It tells us how much information there is in a specific sign that is maybe been in the medical literature for 100 years, but quite commonly nobody has ever explored about how well does it really predict this particular disease. Likewise, for diagnostic examinations, we need to ask how much is the probability of this specific disease in this specific patient changed by a positive or negative test result. That measures how much information are we able to obtain from an examination. This is simply the alteration in diagnostic probability. And that's something that can be counted quite easily afterwards. What is the likely outcome if no treatment is given? This is the study of prognosis and sort of the basis for therapeutic studies. And then finally the question about how much can we improve a patient's probability of survival, probability of achieving a given level of quality of life, functional status by administering this specific treatment. And I'll refer to my favorite scientist, Aristotle. And because he already said that the sciences are not about individual cases, specifically mentioning medicine, that it's not really the question in medical research is can we help a single patient. That is what clinical work is about. But in research, it is about a given class of patients, meaning that we really need to collect extensive and representative amount of data about all patients in a given category. So that is the only way of obtaining systematic knowledge. And this is basically very much the same thing as I was referring to as clinical epidemiology. Okay, so just lists of questions that are addressed through clinical epidemiology or evidence-based medicine. So you start from the very basic one. How common is a specific disease? What is its prevalence? Is early detection worthwhile? Should we screen for this disease with the available techniques? And there I already must say that detecting disease is not enough. We should be able to benefit the patient, not only make a diagnosis. How accurate is the diagnostic test? What is the likelihood that I already mentioned in the previous slide? Does this intervention benefit the patient? What is the treatment effectiveness? And also tracking the side effects, adverse effects of treatment to be able to evaluate the overall benefit. So when we are looking at how well can we distinguish patients with the disease from those free of it, then we be using positive predictive value and negative predictive value. We should be using sensitivity and specificity of the test that we are using, and also be aware of those properties for every test that we use, and follow the advice that those characteristics are giving us about use of tests. Positive and negative likelihood ratios are wonderfully informative measures, but rarely used. I think understanding them would help medical practice quite substantially. And then for treatment effectiveness, the broader question being, what is the effectiveness of this treatment? And the comparative effectiveness research is something that is needed, including all comparative studies, basic randomized trials, but also other, for instance, monitoring the effectiveness in between hospitals, for instance, sort of doing audit and collecting data for audit, evaluating the quality of medical care, patient-oriented outcomes, meaning that really that we should be interested in what is the outcome for the patient. I would never regard very highly research that's only using as the outcome something like improvement in a radiological image or improvement in terms of biochemical indicators, unless they have been already well shown that they are highly correlated, they are valid endpoints for the patient outcomes. So our focus should always be on the patients. Some more technical details, issues that will be discussed during this workshop is absolute effects and relative effects, number needed to treat, I was already referring to. I hope everybody is able to calculate them, well, definitely after this workshop. And understanding issues like what's the difference between a 10% relative risk reduction and a 10% absolute risk reduction, and which is the thing that we should be looking for. And very basic issues such as why are we sometimes using risk ratios and sometimes odds ratios, so those should also be quite clear to you after completing this workshop. And this is just a basic 2x2 table for assessing diagnostic accuracy. After the fact, afterwards we can classify each patient as either having the disease or not having the disease. And then when we observe, if we systematically administer diagnostic tests, we also know whether the results were negative or normal, positive or abnormal, and then we can classify each patient in terms of both the health status, disease status, and the test result as being true negative, no disease, and normal test finding, true positive, abnormal test result and the disease, but there are always also false negative and false positives, which are the important for assessing specificity, test performance for those free of the disease, sensitivity, how well does the test identify subjects with the disease, and the negative predictive value, probability of being free of the disease if the test is normal, positive predictive value, probability of having the disease if the test result is abnormal. And of these measures, sensitivity and specificity are features of the test, so they are not directly applicable to the patient, but they should be used in choosing a test. There are some rules of thumb called SPIN, meaning specific test rules in a disease. A positive result in a specific test rules in a disease. So a specific test should be used for ruling in diseases. Sensitive test, a negative result from a sensitive test rules out a disease. So this should be for excluding a diagnosis for a patient. Predictive values, positive and negative predictive value, are more applicable to a single patient. They tell us the probability of the disease given the results. Likelihood ratios, I was already advocating. There are also positive and negative likelihood ratios, and the value comes from the fact that you can sort of chain them or combine them and always update the probability of a given disease in a given patient once you know the likelihood ratios. And they can be found in the literature. Okay, so what I was saying that in order to practice EBM, you need to have certain capacities, skills, capabilities. I think probably everybody is able to find articles and read them, but that's not really enough. You also need to be able to find what is the key message, what are the most important findings in a study. That's not too hard. Interpreting the results, what do they really mean? that requires already some level of skill, understanding. Then critically appraising, meaning that really assessing whether these results are now really reliable or whether there are major uncertainties in them. That is something that does require some training and understanding. And then finally, the whole point of EPM is really applying the evidence, using it in your patient care. So once you are able to conduct all of those steps, then I hope the quality of care has already improved. And skills are also needed for keeping up to date with the literature. So, for instance, seeking medical literature, which databases to use, which search terms to use, those are important issues. Even more tricky is the skills in critical appraisal, interpreting the evidence, understanding for given type of research and for given publication what are the most important sources of uncertainty and how much do they affect the credit that you can lend to the findings. Understanding the key concepts, and this is really understanding them well, means that you'll be able to know what do we mean by bias, and what do we mean by validity, what is random error or precision and statistical power. Those are important issues in really understanding medical research. Systematic reviews are advocated in EPM as a very important component of the medical knowledge, and as I mentioned, there are more than 1 million papers published each year. The results can be consistent or inconsistent and can be easy or very difficult to make sense of them. Also due to the fact that there's huge variation in research quality, so that basically almost every report that's ever submitted for publication will be published somewhere sooner or later, so there's no so stringent selection in getting published. And just the fact that something is published and maybe printed, nowadays more commonly not printed but only appearing on the web, doesn't really guarantee that the results are valid and reliable. So you need to really sort out the good stuff from the bad, and that takes an effort. And just the fact of compiling all of the evidence is already quite demanding, because typically if you are making a literature search for a given research question, you come up with hundreds and hundreds of papers, and you need to sort out which are worthwhile to be included in an analysis. And what you really want to find out in the end, whether there is an effect of, let's say, a treatment, and if yes, how large is it, and what is it compared with? Is it a new treatment compared with the placebo? If it is, then what can we say about the current standard treatment? What is the relationship of a new treatment to standard treatment which has not been tested head-to-head with the new treatment? And I'll try to dig a little bit deeper into critical assessment. So in order to interpret research results, you want to find out whether you can trust the results, and that is called validity in epidemiology and EBM, meaning study quality or lack of quality, weaknesses of the study. Are the results important? This is what we mean by relevance. Are they applicable? And also novelty. Is there something new that's not already known? Or are the outcomes such that they really matter for my patients? What is the size of the effect? Is it meaningful? Is it clinically meaningful? Statistical significance gets vastly too much attention, and I think the clinical relevance gets much too little in assessing literature usually. Are the results applicable to my patients? Generalizability is an important aspect, and it depends on the patient materials. Sometimes called case mix, means what kind of patients are included in a study. Is it primary care, GP's work, or is it tertiary referral center, university hospital, that might make a difference for the applicability of the results. Of course, whether we are dealing with pediatric patients or geriatric patients is also another world of difference. And when we're reading critically a randomized trial, for instance, you need to pay attention to the inclusion criteria as well as exclusion criteria, because they do affect the generalizability, applicability of the results. And of course, in any given setting where you work, whether you can really apply it, whether the approaches evaluated are available and they can be used in your own context, depends on where you work. And of course, whether or not the intervention is described in the paper in sufficient detail so that you can really evaluate whether it's possible to apply. Validity is a term together with bias that I keep mentioning, and just going to give some detail here. Basically, with bias, we mean any distortion, any sources of error, so to speak. And the major types of bias are confounding, information bias and selection bias. Others will talk about those in more detail, but they are basically due to the imperfections in the design of the study and execution of the study. And there is no completely unbiased study published yet, and I believe there will not be. There's always some imperfection, some uncertainty in any study. But the question is how much? And the assessment of validity can be done both at the level of a single study or in the meta-analysis or systematic review, so how much is known altogether. If you pool all of the evidence, how much uncertainty there still remains. How strong is the evidence for a given intervention? And what makes this also difficult is that sometimes it's difficult to distinguish between bad reporting and bad conduct, because if something is not reported, you cannot assess it. There are several tools developed for this, and Cochrane collaboration has developed something called Acrobat. I'll give a brief, very brief account of it. GRADE is an instrument performed for strength of evidence, sort of overall evidence assessment, and ROBIS is something developed for systematic reviews. And this is just a list of items that were listed by the Agency for Healthcare Research and Quality a couple of years ago. So these are the issues that should be addressed in critical appraisal. First of all is risk of bias that I mentioned already, precision, meaning also statistical power, the spread of confidence intervals, and the amount of random error, applicability or external validity I already mentioned, poor or inadequate reporting also mentioned earlier, selective outcome reporting. This is a major problem. Researchers do tend to report all of the positive results but tend to ignore the negative ones, and if they are completely unpublished, then that will distort also the evidence that is available in the literature. Outcome measures used, I already mentioned, they should be really indicating the treatment outcome that we are trying to achieve for the patient. Survival is obvious, quality of life perhaps, functional status and so forth. Study design, the pyramid I already mentioned, but there are also details in study designs, and just how do you assess the patient's quality of life, for instance, or how do you make the measurements of whatever clinical indicators. Fidelity to protocol has to do with reporting also, and this is why study protocols are nowadays published commonly in advance, so there would be no selection of only the results that you like. And in medical research, conflict of interest is an issue. There's an excellent book called Bad Pharma that explores this issue in detail. These are the issues that are listed in Cochrane's tool, risk of bias tool for randomized trials, and the issues just listed here, including how do we randomize the patients, whether it's possible that there's selection bias due to the fact that we can predict the outcome of the randomization, whether there's blinding of the observers, how the outcomes are assessed, what kind of methods are used for assessing the treatment results, completeness of outcome data, meaning how much dropout there is and whether it might be selective, patients with poor outcome might be dropping out of the trial, and selective reporting I already mentioned. The GRADE instrument for level of evidence advises us to downgrade the level of evidence if there's serious risk of bias in the evidence, if there are inconsistencies between studies, if the outcome indicators are not directly measuring the patient benefit, meaning that you would use only a physiological measure rather than something that has to do with the patient's own experience of their health. whether serious imprecision, meaning amount of random error, and or likely publication bias, meaning that only the positive results are biased. On the other hand, there's also guidance to upgrade the level. We should trust the evidence more if the effect size is very large, if there is dose-response gradient that's not available to all interventions, of course, or alternatively, whether the systematic errors are such that they would strengthen the conclusion. Either confounding would reduce a demonstrated effect if there is any residual confounding, or if confounding would suggest a spurious effect in case that the results show none. And to practice EBM, there are 4 A's: ask, access, appraise, and apply. First, asking a specific question, focusing really on a specific topic, so that limiting the search, for instance, to pertinent evidence. Otherwise, you will end up with hundreds or thousands of papers. Increasing comparability of studies, which is needed for pooling the evidence. PICO or PICO-Ts is used as a brief summary of what is the study about, what kind of patients, what kind of intervention, what is the comparator, what is the outcome, and sometimes time. So in this example, for instance, we could say that the patients are children with acute otitis media, the intervention is amoxicillin, comparator is no antibiotic treatment, and the outcome is becoming asymptomatic. Or another example from the LIFE trial, patients are those with hypertension and diabetes, intervention was losartan and comparator was atenolol, outcome was cardiovascular death, stroke, or myocardial infarction, and the follow-up time was at least 4 years. So this is the PICO summary of a question. And really, the defining the question is critical, has to be specific and has to be detailed, otherwise you will not be able to obtain an answer, which is the condition, what kind of patients, in what kind of population. Just some other examples. In elderly patients with congestive heart failure, is digoxin effective? Does it reduce the need for rehospitalization? Is glucosamine sulfate an effective agent in short-term treatment of osteoarthritis, and so forth? For screening, nuchal translucency ultrasound with serum biochemistry during the first trimester, as accurate as conventional amniocentesis for diagnosing Down syndrome. So these are just specific questions that could be used. Okay, the second step was accessing the evidence, meaning that you should search systematically to identify all studies that are pertinent, and there are many databases nowadays available. Medline or PubMed and Embase are the ones that are nearly always used, but there are also other databases that should probably be used. Then appraise the retrieve studies, already mentioned the instruments available. Also you should use reporting guidelines to assess what kind of data you extract from the studies. There are consorts, trope, and so forth. There is a nice network called Equator that has listed nowadays, I think, more than 20 different reporting guidelines, and those are very useful. Assessing quality and extracting data and pooling the results for meta-analysis. And then finally applying the evidence, because that is the real purpose of EBM. Use the approaches in patient care that are supported by good quality evidence. You should also not only enjoy yourself of those results, but disseminate them to your colleagues. Inform them by meetings, giving presentations, publishing articles of those. Apply more widely in preparing guidelines, service planning, and audit. And also communicate them to the patients in patient care, advice, education, health promotion. So the information should be collected and disseminated. Okay, well, these are just items, some quality assessment items for randomized trials, more or less the same that were already mentioned in GRADE. So these are just items that you should pay particular attention to when reading a paper or when doing an evidence summary. Meta-analysis, well, we'll have a separate presentation on it, but what we need to pay attention to, for instance, is that whether the studies are really similar enough so that they can be pooled. If there are major differences in any of the main components, then pooling them might not make any sense. The numerical results would not be interpretable. And basically, a meta-analysis just gives you a weighted sum of the estimated effect measures. And well, I'll use the very old example from the early 90s about, once again, an issue about thrombolytic treatment, streptokinase in acute myocardial infarction, similarly to the previous forest plot. This is called a forest plot. Every line represents a trial, a single trial. There were many of them between 1959 and 1988. Once again, sort of a mixed bag of results, perhaps a little bit difficult to make a summary of them. However, if you would once again make a cumulative analysis, you notice that already here in the early 1970s, pooling the first 8 or 7 trials would have given a clear indication that the streptokinase treatment does reduce mortality in myocardial infarction. The question is that this was not done, so meaning that, first of all, studies were conducted, at least a dozen of them, that were not really truly necessary because the evidence was already there. We didn't have the EBM movement there. Conducting meta-analysis was not standard approach at that time, but this is just sort of a historical example. So more than 22,000 patients were enrolled in trial and were randomized to placebo when they should have received the treatment that was known to be superior. So just to conclude, there is EBM should be practiced in a circle, starting from a question, compiling the evidence about it, evaluating what is the quality of the evidence, and coming up with the summary measures, implementing the results in clinical practice, and then evaluating how well are we doing. Always making systematic assessments of your own patients. And then probably it's time to come up with a new question. So the good news is that you don't need to do this alone. It's typically done in large consortia, and you can join a team that is doing a systematic review. So you should just join other people who are interested in the same topics and probably have some different skills and expertise. I think a good evidence summary always needs both clinicians who know the substance and the real patient issues, as well as methodologists, epidemiologists, and statisticians who can play with the numbers, so that the people share the goal but divide the tasks, and often there are hundreds or even thousands of abstracts that need to be screened, and so a team is needed. Not a single person can do it, so these tasks are divided to a lot of people. And nowadays it's very easy to work, whether you're based in Russia or South Africa or Canada or wherever, you can still work together. And these are just some recent publications, systematic reviews where I've been involved, and really the questions cover everything from nocturia to epilepsy-related mortality and insulin analogs and cancer. So basically I think a systematic review should cover all aspects of medicine. Okay, so EBM I think means that we use best available scientific evidence and evidence from patients to provide optimal management. And the basics are that you need to have really scientific evidence, not only personal views or opinions or impressions or experiences, but relevant, up-to-date scientific evidence. And there's a requirement for all physicians really to follow scientific progress. Systematic reviews are a good means of compiling and assessing the knowledge. Randomized trial is the best method for creating evidence. And really, I think all physicians should be able to critically evaluate and interpret research. And there are some books listed that are very useful, published on the issue. And there are also very good web pages listed here that you can browse and find advice on how to practice EBM. Thank you.
Anssi, thank you. Вопросы есть какие-нибудь?
Do we have any questions to the speaker?
Guarantee that the paper is with less bias. What's your opinion?
The short answer is no. The journals are interested in something that is novel and groundbreaking. So I have experience in publications where I've been a reviewer for a top-ranking journal, and as I've said, there's theoretical bias in this. But the editors went on, we know, but it's going to be of interest for our readers. So it was the novelty of the finding, not the validity. So impact factor is not a measure of scientific rigor.
Can you give some examples for the audience of the publications which later were shown to be?
Well, actually, John Ioannidis is a Greek-American epidemiologist who's made a whole career, and his most famous paper is called Why Most Medical Findings Are False. And he really lists 20 reasons, one being that, publication bias. If there is no effect, and then the number of studies are being conducted, then the only one that by chance will see something is very likely to be reported. Those who don't find anything, those are less likely to be reported. So there's always this kind of publication bias, only due to chance. And also, if there's a bias that is exaggerating the effect, that's also something that people may be looking at the result and not so much critically evaluate the weaknesses of the paper. So I think it's very obvious that there is strong bias for finding something or the positive findings to be reported.
Thank you.
And of course, the researchers always like to see something. So if I don't see anything in the main analysis, but there's this subgroup of whatever, and then that might be even presented as the main finding, which was not originally the case.
Okay, thank you. Еще есть вопрос у кого-нибудь, может быть?
Do we have any more questions from the audience?
Did you hear about the situation in the United States when? Thank you. When some institute made systematic review, and after that asked research centers to confirm data and send data to them. Mm-hmm. And only 15% of research centers really send this data. Yeah. How can you comment this situation?
Yeah, it's a good question, and it's a real issue. So that if reporting is not truly complete, and you cannot abstract everything, all of the main results from the publication, then what some people doing a systematic review would typically do is, as you said, they would contact the researchers and ask for the data. Possibly the data itself, so that it can be analyzed, or even the main results, the numerical results, how many events were there in this group and how many events were there in that group. If you don't get them, that's clearly a limitation for pooling for pooling the data, and it's a limitation of the whole systematic review. And it's something that I don't think we have resolved.
And should, for example, Cochrane collaboration demand data from randomized controlled trials to make their systematic reviews better?
Yes.
How do you see it? Should they demand data, and will it be applicable for scientific society?
Yes, they do, and nowadays I think this is less of a problem than it used to be, because the major journals nowadays require that if you want to publish, then you will have to put the key data available somewhere on the website of the journals or on your own institute or somewhere else. So that nowadays, if you really want to publish in a top journal, you cannot do it unless you put the data also publicly available.
Okay. Thank you.
And I think that's a very good trend.
Еще вопросы есть у кого-нибудь?
Any more questions?
No, not from the top of my head.
Я думаю, что thank you very much. I think we'll